Welcome to Let's Talk, the half hour where we join various guests from around our community. Now, let's talk.
Welcome to the program, listeners. Tyler Friel with you on WISR 680 AM, 107.5 FM. This is Let's Talk, the half hour where we sit down and chat with various organizations, businesses, nonprofits, and more. And today we sit back down with Independence Health System. We are joined by Alayna Link, a nurse practitioner, and Dan Kennihan, a PA with the hospital. And we're going to be talking about cardiology today. Guys, thanks so much for taking the time, and welcome to the program.
Thanks for having us.
Yeah, absolutely. Thank you for having us.
Great to have you here. So before we dive into this and get into a full conversation about preventing heart disease, it's going to be our main topic today. We want to remind you, hey, if you can't stick around for the full half hour, we do have you covered. You can go online to WISR680.com, look under the programs page. There you'll be able to find Let's Talk and all the shows that we've done with Independence Health System. Also, we're available on Spotify as well. So if you're a Spotify user, you can just search for WISR Let's Talk, and you'll be able to find all of our shows there as well. But we are talking about heart disease today with Independence Health System. So, Dan, I will start with you. As you know, you take a look at heart disease, and I think a lot of people hear that word, hear that phrase, but they may not know exactly what it means. So if you were to generally to describe heart disease, what would you say?
Well, essentially, your heart not working like it should, and it can be caused by numerous causes, of course, uncontrolled hypertension, blockages in the heart. Sometimes it can be a genetic predisposition to having these kinds of things.
So when you're talking about the prevention aspect of it, because I think that's what we want to focus on today, what stands out to you? Like, what's one big thing that you would tell people, hey, when you're talking about preventing heart disease, what's one of the biggest things that you would tell people?
Across the board, for sure, exercise. I know a lot of physical therapy, or I guess, both agree that exercise can be medicine. It's one of the most important pills that you can take. To me, that's why I try to tell patients that I see in the office, something 3 times a week to get your heart rate elevated for 20 to 40 minutes, make that heart work. That can go a long way in preventing heart attack, stroke, and just your overall health being improved when you engage in regular exercise.
And Alayna, is that something that we can start at any point? Because there may be some people, especially we talk about it all the time when we flip the calendar to a new year, some folks really make that dedication to exercise. Let's say somebody hasn't been as active as they want to be. Can we start this in our 50s, and will that show benefits with our heart health?
Oh, yes, of course. And I'm telling that again to my patients all the time. Heart disease is the leading cause of death, and it's super important to prevent, and exercise is one of our main recommendations. Just doing, even patients are like, well, I can't exercise, it's really hard for me. And it's just like, even walking, that's the best thing to do for your heart, is just, walk, get out there and walk a little bit.
And that's what some people may hear the word exercising, and it could be intimidating, right? They may start thinking, oh, that's the gym, that's running on the treadmill. Nope. You're saying that's not the case, right?
No, I think I always tell my patients, if you're nervous, start off with, even 15 minutes, just walking. Walk around your neighborhood when it's nice out, get a treadmill, walk on the treadmill, 15 minutes, make your way up to 30 to 45 minutes. But like Dan said earlier, anything to increase that heart rate, make your heart work, walking, I think, is the best medicine. So.
And Dan, on the exercise front, as Alayna kind of laid some things out there, what data do you guys see, or maybe just even personal experience with patients who may have been somebody that comes in with symptoms and then they start to do some just simple exercises, getting out, being more active? What have you seen in your time as a PA as, hey, this is visual evidence that we're seeing somebody get better?
Yeah, I think a simple example is you'll get a patient that comes in and they're a little short of breath, and they've had a lot of testing, have had the general echo, stress, all the other little things that we do in terms of making sure that there's nothing serious going on. Once we do all of our investigations, sometimes we're having a conversation of, well, everything looks good, your shortness of breath could be due to being out of shape. And sometimes that's a tough conversation, but most people receive it well. And I've seen it where you get a person who starts to increase their cardiovascular exercise, do a little more, a little bit of walking here and there, cleaning up their diet, of course, which is also extremely important. They come back and say, hey, yeah, you're right. that walk up my flight of stairs at home is easier now, and all I did was increase my exercise on a daily basis, and it doesn't have to be daily. And kind of expanding on the methods, some people have a lot of things that limit them from doing an appreciable time on the treadmill or going into the gym. And I always reiterate to people who have orthopedic knees or any other kind of joint issues, it doesn't have to be the treadmill. It doesn't have to be the weight room. I commonly point people to water aerobics. They make little devices that you can set on your floor or under your desk. I think one of them's called a QB, starting with a C, and it's basically a stationary bike that you can use at home and just do at home. And again, that's something that can get your heart rate elevated if you're doing it consistently. And again, we see where people do get feeling better overall when they engage in regular cardiovascular exercise in conjunction with a healthy heart, healthy diet full of, less of sugars, less of empty carbs, and more of legumes, nuts, fish. There's this whole concept and culture of being afraid of red meat and it throwing your lipids out of whack and increasing your risk for cardiovascular disease. And there is a little bit of evidence for that. And when people come in and say, oh, does that mean I shouldn't eat red meat? My answer to that is, well, it depends. What's your risk? Have you had a heart attack? Have you had lots of things going on? And in general, I err on the side of, it should be a delicacy. Your meal every night probably should not be a big fat red
36-ounce porterhouse.
New York strip every night. Make it a delicacy. Make it something that's not an everyday thing. Moderation, just like all the other wonderful pleasures in life.
Absolutely. So sticking on that diet, I know we hear, again, New Year, you always have these conversations about exercise and diet. And so, Alayna, if you're giving somebody just a good rule of thumb, I know Dan kind of laid a few things out there, but on the diet side, what are some of the things that we could do that would be simple adjustments in our grocery store shopping habits or whatever it may be that, hey, this is something that we could add into the fold that we know is going to lead to better heart health?
Yeah. And diet is tricky, especially here. I feel like, telling someone, at least in our patient population, telling them to stick to a diet is sometimes a financial constraint too, So I would just say make good choices, try to include those lean proteins, try to avoid, like we talked about, red meat being a delicacy, avoiding those carbohydrates, really focusing on getting a lot of vegetables, fruits, things like that. I know diet plays a big role, in preventing heart disease. But like I said, these financial constraints can be a problem. So just making good choices, lean proteins, focusing on a lot of fruits and vegetables. And
do you find that as people, it may be challenging, just like on the exercise side of it, it may be challenging at first, but once they make these transitions, that it's a little bit more comfortable for individuals?
Yes, 100%. It's always hard, even for me in everyday life, making these changes for myself, So it's sometimes hard to, expect these patients to be able to make these changes, but once they make little changes, yeah.
Well, you mentioned the grocery store shopping too, and when I talk with dietitians from the hospital, we always talk about kind of those trickier items that are out there that may be perceived to be healthy, but also really aren't. Mm-hmm. How do we become a little bit more of an agile shopper, more of a knowledgeable shopper when we're doing our grocery store shopping?
Well, I try to simplify the recipe for people, because there's a lot of fad diets out there, and some things work for some people, some things don't. Across the board, if someone's not willing to see a dietitian or that's too much to ask, I try to tell them to simplify things into the basic concept of calories in, calories out. There's calculators online you can use to estimate your daily caloric intake and what it should be based on your age, gender, weight. And you can just simply start looking and paying a little more attention to the calories that you're putting in. And you'll find, and most people find, if I eat this bag of chips, I'm destroying most of my caloric intake for the day and can't eat much more if I'm going to, abide by that calories in, calorie out routine if I'm trying to be on a deficit or even just maintain. People will start to realize what foods make them more full, and are calorically better in the sense of you can eat more and you're not eating half of your caloric intake in one sitting.
10 chips are going to be add up quickly as opposed to whatever
so
it may be.
I tell
carrot
people
stick.
Exactly. I tell people, look at that nutrition label, and people get caught in the trap of, there's only 200 calories in this bag, but if you look, look at the serving size, 200 calories per serving. There's 20 servings in this bag. That's a lot of calories, and sometimes that can be missed. And of course, the foods that taste better typically have more calories.
Absolutely, it's one of those dangers of life. Unfortunately, we have to deal with.
I think in terms of this conversation of preventing cardiovascular disease with exercise and diet. There are certain things that we know that the research has consistently shown increase your risk of cardiovascular disease, smoking being that big component. And that's tough. Everybody has a vice. Life's hard. Everyone looks to that one thing that gets them through their everyday. And I always tell patients we are always here to provide education, resources to get away from that addiction, because it is addiction. It's hard. It's difficult. But it certainly can lead to worsening cardiovascular disease and respiratory disease at that.
Well, and I think a lot of people, when you hear smoking, they do make that connection, and we've talked with a number of doctors from the hospital about the lung cancer risk, right? But you said smoking, there's a lot of studies and research that shows how that impacts the heart. Let's get into a little bit more of the science behind that. What happens? What do we know about that?
Well, bottom line, you're combusting something into your lungs. You're causing free radicals to be exposed to the lungs, which can cause damage. All the components that get absorbed into the bloodstream can cause damage to the endothelial cells. So that's the thin lining of cells between the lumen of your blood vessels and the muscle that surrounds it, that constricts and expands for the basis of blood flow. And that is kind of at the heart of the pathophysiology of atherosclerotic disease, is that endothelial dysfunction. That's how plaque can start disrupting the function of the endothelium, which plays a large role in how the vessel works and what can happen. And that's when this plaque from cholesterol can invade underneath that endothelium, and you start to get the buildup of these atherosclerotic plaques that can, over time, block off the lumen of the vessel. Now you have less blood flow coming through that vessel, and it can happen anywhere in the body. Of course, when it happens in the heart, that's when people start to develop the symptoms of having cardiovascular disease: chest pain, pressure tightness with exertion, shortness of breath. That's new for them while they're walking around and doing activity. And that's because of lack of blood flow to the heart. The heart cells are not working like they should, and the symptoms that they get are a result of angry heart cells because they're not getting enough blood flow, enough oxygen.
Alayna, we talked about the exercise portion, where somebody who hadn't been exercising for 10 years, if the heart sees improvement, if they start exercising now, does smoking fall into that category? If somebody were to stop, do you see improvement in heart health?
Yes, I feel like you do. I mean, at every visit, I'm stressing to my patients, like, yeah, I get it. You've been smoking for many years, but stopping, yes, that's going to prevent, heart disease, and definitely,
So those three that we talked about, diet, exercise, smoking, a lot of the big ones when it comes to heart disease. I do want to talk about genetics, though, and I think you mentioned this, Dan, at the top of it, that some people they may be, they may be eating right, they may be exercising. Are there some circumstances where genetics are just going to play a role?
Absolutely. A simple example is, like I said, plaque formation can be a result of having abnormal lipids, your LDL cholesterol, to be specific. That's something we watch very closely, and your diet can play a role in that, and genetics can certainly play a role in that. Not that that's the only genetic predisposition to having coronary disease. It's certainly just one example. And controlling that cholesterol is also an important way to prevent cardiovascular disease. So that's something we watch when we're in the office, and when someone has a high cholesterol and has high risk factors. We haven't even got to diabetes, funny enough, so much, which is another huge risk factor, if not one of the most important risk factors for having coronary artery disease. These people all have to have close contact and close following up of their cholesterol and good diabetes management.
And I think that's one of the biggest messages that we kind of want to get out there, how it's really important, to kind of look at yourself and, make sure that, if you have any of these risk factors, if you have high blood pressure, if you're a smoker, if you have high cholesterol, family member that had high cholesterol, or family member that has, history of heart disease, I think it's super important to, seek treatment early. We can calculate your ASCVD risk score, which is an adverse cardiovascular event. We kind of calculate this score. The score is calculated based on factors like if you have high blood pressure, if you're treated for high blood pressure, if you had your cholesterol checked recently, we look at those numbers, if you're a smoker, not a smoker, and we kind of get this risk of you having a, adverse event from cardiovascular disease within a 10-year period. It can give us guidelines on how to, do we put you on a medication like a statin? What do we do to decrease your risk? So I think the biggest message, we want to get out there is just, it's really important. If you have risk factors for heart disease, risk factors like we talked about, high blood pressure, high cholesterol, tobacco use, diabetes, family history, really important to, seek care sooner rather than later.
And as we talk about that, you mentioned a lot of the risk factors. Let's say somebody does get to the point where they may be starting to experience symptoms of heart disease. What could they expect? What are some of the things that an individual may be experiencing that would be indicators of heart disease?
So biggest symptoms, I feel like I tell my patients are always like, well, how do I know? Like, what if something's happening? What am I going to feel? And like Dan kind of touched on earlier, cardiac pain in your chest, feels like a pressure. Someone's sitting on your chest. It can radiate into your back, into your arm, into your jaw. Usually get other associated symptoms, shortness of breath, nausea, breaking out into a sweat. Symptoms usually occur with exertion, resolve with rest. But those are definitely warning signs, symptoms that, hey, maybe something's going on. I should probably seek care. And that
would that be considered a heart attack? How do we know what crosses the line from a heart disease symptom to what a heart attack actually is?
Well, obviously if you're sitting at home and you have a sudden onset of symptoms such as the chest pain, the shortness of breath, and you break out into a sweat and you're nauseous, those, you can look in a textbook, those are classic symptoms of an MI. And if that doesn't go away with rest and it's ongoing, you certainly shouldn't wait. You should at least go to the emergency department, seek care, and based on our evaluation there, we will be able to make a determination if you are actively having a heart attack based on your electrocardiogram, your troponin. Troponin's an enzyme released from the heart under stress, and we have very sensitive laboratory measurements for this these days. So if someone's not having an acute heart attack based on their evaluation by a provider in the ED, we usually get them in the office, and at that point we start talking about, well, how else do we modify their risks and modify, essentially, I guess I should better say, screen them for having any significant blockages, because some people can still have coronary disease and they won't have that troponin or EKG changes, and that's not uncommon. So these days we have lots and lots of ways to evaluate this, from non-invasive methods to invasive methods. Something as simple as like a treadmill stress test, which we've been doing for numerous years, all the way up to, of course, an invasive procedure that our cardiologists do, a left heart catheterization or coronary angiography, where the doctor pulls you in, you get images of your heart vessels under chest x-ray with a dye, and of course that's the invasive endpoint, and that's the procedure that people can have serious blockages opened up by stents and any other procedures. And unfortunately sometimes people end up needing heart disease if they go along, or needing open heart surgery, if they go long enough without having any symptoms that would suggest they needed any testing. Sometimes people do come and they're just late presenters, and that's how it happens. But going back to the point, if you're having symptoms, see your PCP. They may or may not send you to us. We do all those things in terms of your EKG, checking your cholesterol, checking what other risk factors you have, like diabetes, high blood pressure, and we try to modify those risk factors, get the blood pressure down. Maybe someone needs a statin, it's cholesterol medication, to bring down their LDL. These are risk modifiers that can improve the possibility of having blockages. And that's all said and done, providing that they've had some sort of assessment of their heart to note that there's no evidence of any significant blockages. Because sometimes people get chest pain, and that does not automatically mean they need to go to the cath lab and have a stent, but it might mean they need risk factor modification and maybe medications to make that chest pain not come about as often when they're doing exertion. So I think that answers the question about an acute heart attack and going to the ED, circling back to the start there.
But no, I think it brings up, and you talk about, and I heard you mention, being with your PCP, especially is in Alayna, maybe if you want to go over some of these risk factors again, that would really encourage folks to make sure they do talk to their PCP and work through this, because at least it seems at this point in the conversation, it's important to get on this earlier rather than later.
It is. And again, touching on those risk factors, like we said, high blood pressure, big one, high cholesterol, being a diabetic, being a smoker or former smoker, and family history, of course. I always ask patients when they come in, do you have family history of heart disease? Meaning, grandparent, parent, suffer a heart attack or have, heart disease before the age of 60. Really important things that we kind of address. And then, if your PCP decides that, you should see a cardiologist, we have, many offices in the Butler area and outside areas too, and, we're always available to see patients. We're always accepting new patients in our office. We have an office here in Butler, the Crossroads campus. And then we have many outside locations in Clarion, Elwood City, Indiana, Seneca, PA, Seven Fields, Slippery Rock, Katanning.
All over.
Oh, yes. Oh, yes. And we're always welcoming patients. And sometimes it's hard, transportation plays a big role in that too. We do offer, virtual services as well. So any concern at all, any of those risk factors, important, to stay on top of it, see your PCP. You can always even call our office, get an appointment if you just want, set up. If you're worried, we're always welcoming new patients, and we're always available to see patients. So
I know you talked about some of the interventions there, whether it's something simple as diet, exercise, but also on the medicinal side, what medicine-wise could some people be involved in if they are deemed that, hey, this is the necessary thing to do?
So, if we see you in the office and we determine you have high blood pressure, it's not controlled, there's many medications to treat high blood pressure out there. If we see, we run a cholesterol check and your LDL is out of control and we determine, you have risk factors, you need to be on a statin to lower that, we offer medications like statins.
There's just a lot. There's obviously a lot on the table here.
Is.
But I'm always curious in regards to the newer technology, and I know, Dan, you kind of gave a good rundown of things there, but what maybe has changed in the cardiology department, let's just say over the last 10 years or so, that is a new tool that the hospital has?
Yeah, I'm glad you asked. I kind of touched on the exercise stress test that we've been doing forever. Of course, there's a nuclear imaging component to that, pharmacological component to that, where we can get images after we inject a nuclear isotope, and our cardiologist will read this image before you have either true exercise or pharmacologically, quote unquote, induced exercise with medications. And they look before and after and they see, are there any differences that might denote if there's possible disease based on the lack of perfusion to the heart. That test is not always perfect. What's changed is that we are now doing something called coronary CTA. So CT of the chest with dye. We have some cardiologists who have really taken hold into doing this testing as a way to prevent sending so many people to the cath lab for that invasive procedure, which again, it's a low risk, but not a no risk procedure. Things do happen, things can go wrong. So we generally try to avoid that if it's not needed. And one of the ways we can do that is this coronary CTA. We get beautiful pictures of the coronary arteries. Dr. Carey, Dr. Pinto have headed that at our office, and we have that available as a option, as a ischemic workup if someone's at an intermediate risk for having coronary disease, maybe has some symptoms that aren't that classic exertional chest pain or shortness of breath, but pains in the chest that we don't have another explanation for. They can go have such a test, and we can get pictures of the arteries and say, oh, well, you got nothing major blocking. You don't need to go to the cath lab, but we can find some residual disease that's deemed non-significant, meaning it's not blocking off blood flow, but you still have it there, and there's something we can do about it. That's when we look not only to the lifestyle modifications, stopping the smoking, getting the exercise, eating a good diet, but also the medicines that we know that prevent the frequency of major adverse cardiac events, the aspirin daily, the statins to control the cholesterol, anti-anginals, beta blockers to reduce the heart rate, reduce the work of the heart, other medications that can dilate the vessels of the heart and allow a little more blood flow to get to that myocardium. So we're really excited about this coronary CTA. We're not quite to the point where people are coming to the ED with chest pain and not having that high risk troponin in their blood and getting a scan and saying, nope, you're all good, get out of here. Not quite to that point, but it sounds like we're hoping to get there. I think it's really going to change the field for how we're thinking. And I think overall, when someone does a stress test or that nuclear imaging, we get evidence of any major blockages, but they're not, like I said, it's not perfect. You could have disease. So getting that coronary CTA does allow us to see, is there any plaque in the heart? How can we modify your risks by controlling some of these factors.
How do patients, Alayna, respond whenever they get, I mean, these diagnostic tools seem to be really advantageous for you guys on the medical side, but for the patients to have now all of these different available tools for them that make your jobs easier, but how do the patients get that feedback? How do they take the feedback? And what's it like working with a patient to kind of walk them through this process of diagnosing exactly what's going on with them?
I feel like it's sometimes tricky, and it's a process that takes a while. And, I think just getting you into the office and discussing these things it's a big deal. And, when you're sitting there and telling someone they may have heart disease and, you're offering these different tests and things, it's overwhelming, right? It can be like a thing that it's kind of shocking. I mean, I know it's overwhelming to me, as a provider, and hearing it from the patient side can be as well.
One thing we always like to talk about whenever it comes to any of these hospital departments, one thing is you note how vast the offices are on the cardiology side. But what can you say, Alayna, about the team that you work with? When people go to the cardiology department through Independence Health System, who are they working with? Who are the people that you're working with on a day-to-day basis?
So we have a wonderful team, I feel like, here at Independence Health, the cardiology side. I work with amazing cardiologists. I believe there's like 11 or 12 cardiologists now, and 11 to 12 advanced practice providers, so nurse practitioners, physician's assistants. And then we also have, the electrophysiology group, which is growing as well, seeing patients, Elwood, Sharon, Newcastle, all those places. But yes, I'm very proud that I work here, very proud of everyone that I work with, and we all work very well together as a team. We see patients, we get them in, get, treatment moving forward, and Dan, what's it like for you to work with this team, but also get to track these patients, and especially the ones that are yielding positive results? What's it like for you to watch?
It's an overwhelming blessing, honestly. As Alayna said, we have cardiologists, and across the board, they care. They're amazing at what they do, and they're supportive in our day-to-day interactions with patients. And absolutely, when you see a patient who has maybe had an event, had a heart attack, they get the right therapies, and they're improving, and they change their life around. Hopefully, obviously, ideally, they stop smoking. They get their blood pressure under control, and we have the cholesterol under control, and we see them every 6 months to a year and make sure that they're doing those things and keeping them motivated to stay healthy. And of course, let us know if anything's changed, if they start having new symptoms. Once you have a heart attack once, you certainly can have it again, even if you're doing all the things right. That's kind of the nature of the beast. But yes, it's been a great experience at Independence Health with our group. I think we're well supported, and I'm happy, and I think most of the patients that come to see us are certainly happy.
I agree.
For those who are interested, as you mentioned, heart disease, this is the number one cause of death for men, women, and people of most racial and ethnic groups in the United States. It's prevalent. It happens. For people who have concerns about what their heart health may be, we've talked about the risk factors. Alayna, what are the best ways to reach out? How should this process look if they want to start the conversation with Independence Health System?
Definitely calling. We have a main line that they can get a hold of, just, Independence Health. It's just Butler Cardiology Consultants, and just requesting an appointment, and we're always, like I said, open to see you, in person if you can make it. We have many, many locations, as I stated earlier, or if transportation's a problem, we definitely have, virtual visits as well.
Fantastic stuff. Alayna Link, Dan Kennihan, again, with the cardiology department at Independence Health System. Thanks so much, guys, for stopping down and taking the time.
Hey, thank you.
Thank you.
Hey, if you missed any of our program,